I am an orthopedic surgeon by trade. For those that are not medically inclined, that's the doctors for bones. And yes, I'm not a stereotypical, big guy muscles. And that's why I'm the only female at the Chris Hani Baragwanath orthopedics department. Okay, the only black female there. So I was fortunate enough to be subsidized by government to actually go overseas to study further, to do hand surgery, right? So in coming back, I obviously got exposed to the health system in the US for a year and a couple of months in China, where I also wanted to learn a lot about the injury on duty. Our country is developing just like theirs, so they have a lot of hand injuries. So in their system as well, I learned how they run their health system. So I was privileged enough to actually be exposed to both of them. Although I do know the NHS in obviously Europe and also in Canada. So in being there, in the US, as much as it's a true first world capitalistic, the one thing that really did shock me was the fact that in a first world, you can walk into a health system, get obviously acute care, but then if you don't have money to pay for medication, you're literally sent out to say it's your responsibility to get an antibiotic. So imagine a patient that actually cannot afford it. So as much as from the TV and all of that, we all see, oh, Obamacare, that's actually bad. I actually understood why that bill was important, Obamacare, because you cannot have a first world like that, and yet you cannot give basic rights to human beings. For me to be able to treat somebody 3 times, they come back to casualty over and over because they actually do not have money to go buy an antibiotic privately. So that system exposed me to that. So I realized, even though I knew that about myself before, but I realized that we cannot let our system get to that point. And where it is now, it might actually get to that point. Because even as a super specialist, I pay a lot of money to medical aid, a lot. And I'm actually not even using that medical aid, by the way. So I'm actually subsidizing a lot of other people, like the CEO, as he said. So I'm also a member of PPF, and I am part of the Limpopo outreach. I am from Limpopo, so don't judge. So I actually joined Professor Machita.
So Limpopo is also bringing doctors.
So I'm part of the MEC of Health there, Popi, Ramatuba, and also Machita, who came up with the MOPA projects. Limpopo, they don't have specialists. They struggle a lot, especially orthopedics. And we know orthopedics, when it comes to litigation, government spends a lot of money on litigation on obs and gynae and also on orthopedics, right? Because patients can lie in hospital for 3 months waiting for their femur or their long bone to be sorted out, and then the next thing it complicates, and then we get sued as government, right? So we go every 3 months, and we decided to actually do it pro bono because, again, we worry about corruption. So we said, look, it's up to you. You can come every 3 months. The only thing that government will cover you for is the accommodation and obviously pay for implants that are required or whatever. So I'm part of that. And also in coming back, I realized that I am a solution-based doctor. So working at Bara, 3rd largest hospital, the busiest hospital, right? And obviously looking at trauma, a lot of trauma is orthopedic trauma. So most cases that actually come into casualty also have orthopedic issues. So in coming back, I realized, how other people sorted out resources. So like for instance, we have an open door policy. So you cannot have a patient who has a nail bed problem, like you crushed your finger and then it's broken or it's got a laceration, and you walk into a tertiary institution only to be admitted for 3 or 4 days because we've got a bottleneck issue of patients waiting for theater, especially emergency theater. So imagine a patient with a simple finger problem, where in casualty we don't have an area where we can treat these. The patient is then admitted, and then the next thing, they always have to be bumped on the list because, oh no, someone else is coming with a step heart. Someone else is coming with emergency Caesar or something like that. So they end up actually being bumped. But what are they doing in that meantime? They're actually occupying a bed that is required by other people. Right? So then I learned from US and also in China that you can create a mini theater in casualty, right? So I came up with that project. asked for a spacing in casualty and actually created what they call a minor operation room, where you just block the patient, the finger is numb, you deal with the issue, and the patient goes home from casualty. So they enter and they leave, right? So I actually got awarded the Kanyisa Best Performing Doctor in Gauteng for that, right? So the MEC covered the problem with our current system. The fact that we are actually servicing 85% of the population with only half of the GDP, like he explained. So the disparity that's actually along the income levels, it's not sustainable, honestly speaking. I know that there's issues like Prof covered, but if we have to look at just as human beings, the system that we have now absolutely is not sustainable. Obviously, in dealing with it, we have to have lots of discussions and be realistic about the issues that we have. So the government, already subsidizes our education. People don't understand that in the US, people struggle with just going to medical school. People don't understand that going to medical school, you get subsidized a lot by government, only for some of us to then leave to Europe, and then some of us actually go into private. So government already there loses. The government also subsidizes medical schemes, like MEC then explained, and most of us that are actually working for government, and then you've got a medical aid, you end up going to a private hospital, therefore taking that money to a private institution. So, and then with issues like doctors leaving to obviously private, and issues that now government does not have enough money to even retain some of our doctors. In Limpopo at the moment, we've got issues with the medical officers that cannot be retained because government just doesn't have money. So then they have to outsource and say NHLS or the private institutions have to help us with accommodating these doctors. So therefore, we're actually losing the whole idea of what a medical officer is supposed to be, which is somebody who's supposed to be trained so that when they finish, they can actually go and work in a local hospital without any assistant. So then with all these issues being mentioned, how do you then deal with the issue of demand versus capacity? So that's, at the moment, we're actually reaching, with looking at our stats, just in orthopedics, we realize that we have a problem with demand and capacity. There's a lot of patients coming in, and the bottleneck is literally in theater. We have a long waiting list of hip replacement and knee replacement to 2024, right? And this is a big issue because now patients are going to start complaining and saying, but government is actually not helping us. How do we wait for such a long time for a necessary operation? And the issue is some of them, it is so bad that by the time we get to a gogo who needs a hip replacement, you then phone only to find out that, oh, she actually passed away while waiting for a hip replacement, right? So the answer to all these problems, I understand that it can be NHI or access to healthcare and quality healthcare, right? But the one thing that we do need to understand is that we must also look at our current system. That's where my actually biggest issue is that I understand it's a beautifully written policy, all of that, and the issue that first problem I have is on this brochure, it's written, government will upgrade all facilities to ensure that there is no difference between a public and private facility. I think that statement sends the wrong message to our population, first of all, because they'll never look the same. But obviously, the quality of care or the necessities that are there, they will be the same, but not necessarily the facility itself. So let's not lie to the people so that they know what they should actually expect. Bara will never look like Busamed. I also work part-time in Busamed in a private hospital. It'll never. It's a beautiful hospital, but we must have the basic care. So I would say let's look at the current systems. What's actually good? We can all criticize and stuff, but we all need to also come up with solutions. What is actually working? I know that our medical training is very good, so we obviously need to keep that up and maximize on that. But what are the things that are actually not done well? And the issue, honestly, on the ground as somebody who works day to day at Bara, of which you need to understand, because you also come from that system, is that on a daily basis, we have an issue of patients' backlog. Not just for chronic, but also for acute, right? And with the issue of just having an open door policy, you have a lot of patients coming in with something that can be treated by a GP or even a clinic. And the biggest issue also in orthopedics, because we use a lot of implants, the plates and screws that you have to put in patients when they've got broken bones, and also for the hips and knees. We find that with the supply chain, that system needs to be really looked at. Because one, I think as much as people can say, but government can negotiate. There's some implants, I tell you, I work both for private and public. There's some implants that I'm telling you, we're actually paying double or triple as government, because there are those open areas where people are like, oh, this is an opportunity for me to actually overcharge. I'm telling you, as much as we can say, oh, we do negotiate, so those things need to be actually looked at. So how will NHI actually help us? So I think one, the universal access, which is good, that at least everybody has got access to healthcare. But the important thing there is, I think we shouldn't negate primary health care. I know that previously this was the big issue, but I see now with the newer version that it's not really highlighted. So I would say, let's highlight primary health care. What does this mean? This means we really have to check up our clinics. Patients, this is actually when you roll it out. I would say suggestion is don't roll it out all at once. You must actually start step by step, right? So step by step would be emphasis on primary health care, meaning that the clinics, community healthcare centers, and actually the GPs get involved. How will this improve this, or this make sure that there's a difference? Then patients don't have to wait long lines at Bara to actually see a doctor for an ailment that they can be seen by a GP or a primary healthcare physician. So you'll see actually the difference very early on if you emphasize on the primary health care. This, for instance, if a helper who lives in Soweto works in Bryanston, she starts actually feeling unwell, this gives her access to go to one of the Bryanston GPs, instead of then taking a taxi, going all the way to Soweto, and then go to Bara, wait many hours, only the next day to actually go back to her work. These are the people that we need to take care of. Because as much as people can say economies run by big companies and whatnot, these are the guys that actually run our companies. These are the workers that work in your factories that actually say they are running the economy. So we do need to take care of these patients. So regulation of the prices, that will also help if government gets involved in all of that, because you cannot have somebody saying, I charge 100,000 for a hip replacement, and someone says, oh, I charge 30,000. That disparity is just, that doesn't make sense. And that's the biggest issue that we have. And that's why some medical aids like Discovery have started looking at trying to regulate that, to say, look, we do know that this implant does work. We do know that it's got a good outcome, and then this is the pricing, and this is what we'll actually pay for. So that has got its positive to actually do your regulation of pricing, and also looking at equipment. So number 3, it will help with litigation. So just us doing outreach, which you can also call mini, sort of like an NHI, we're giving access, but we actually have to travel as doctors. So litigation will decrease because you'll give quality care early on, done correctly. So you don't have to worry about litigation. And then the biggest issue for me is the implementation. I also agree with Prof that it looks great and all of that, but the biggest issue is implementation. So in implementing it, you have to look at the current system and improve it. There's lots to improve, absolutely lots to improve. And then we have to go back to primary health care. And we also have to look at the fact that NHS, if you look at the Europe and Canada, they actually have a lot of administrative work. So that sometimes people forget to look at your IT systems. I mean, Bara, we're still paper-based. Other people are, like Sheldon McLaughlin, they're quite lucky. I think the x-rays, they've got the PEG system where you can look at an x-ray on a computer. We don't have that at Bara. So we need to look at things like that. So the claiming process, that was one of my personal concerns for the doctors. Working in private, I do the workers' compensation and road accident fund. We struggle a lot. That's why there's a lot of doctors that are from like Pretoria that would say even their hospitals, they don't do injury on duty, or they don't do RAF, because there is a problem with the payment process for doctors that have to wait. So I worry that if we do the NHI, how will I survive as a human being if I'm actually working in private and I see patients that are WCA and RAF, and then the next thing I don't get paid for 6 months or for a year? How am I going to actually survive? And then my other concern is trainees, the interns and the registrars. How will they then be incorporated in NHI? And one of my also biggest concern was the board and committee appointments, like Prof says. For me, there's also one person choosing the whole board and the committee. I worry about that. And I worry that will we be represented? The people that are actually on the ground day to day that are dealing with these issues, will we be actually included and represented? The protocols, we all know for emergency medicine, for pediatrics, and also for obs and gynae, you guys have a lot of protocols. But for other units or for other people, who will then be in charge of doing these protocols? In orthopedics, there's a million ways of treating a femur, preference. So how do you then say, we're actually going to treat it this way? Does that take away autonomy of doctors deciding how they want to treat patients? So in conclusion, I do support the universal health. I do support it. But its implementation, we really, really have to make sure that we get it right from the word go. Because if we don't, this is a disaster you do not want. Because if it fails, it will be an epic, epic fail. And in doing so, obviously, wanting to win a war, you need to win the small battles. So let's just start small, preparing for it. Obviously, that's the direction that we absolutely have to go, but we need to actually make sure that we, as we are marching towards NHI, can we please just solve the issues that we have at the moment? And another suggestion is obviously the day hospital incorporation, because for me, working in the hand unit, I realized that you can save a lot of money when patients actually come from home. They do the surgery, they go home the same day. So we actually have a day hospital within Baragwanath called the hand unit next to the burns unit. And that's what we do. And that actually saves time, that saves beds, and that saves money. So that's something that we actually need to do more and more of, because internationally that's what people are actually moving towards, day hospitals. Thank you.
Thank you, Dr.